And we're live in 5,
4, 3, 2, 1.
All right.
Thanks, Corey. Hey, welcome, Arthroplasty fans. This is a special edition of our Arthroplasty series. And usually, this is case-based, and we have a good time showing the good, bad, and ugly cases. But this time we thought we would do something different. And really, for the first time that I know of, get the inventors of the 3 lumbar discs that are commercially available in the US together. And we're happy to be able to do that and kind of have a conversation about looking back at the last 20, 30, and even 40 years of arthroplasty development. So we'd like to welcome live from Berlin, Karen Büttner-Janz, who's staying up very late for us, Terry Marnay from Montpellier, France, who's also staying up very late for us, and Rolando Garcia from Miami, who's not staying up quite so late, but is staying up late. So just a very quick introduction to many of you who may or may not know that is Karen is the inventor of the Charité disc. Before she was an orthopedic resident, she was a gymnast for the East German team. She was in the Olympics, Karen, I think in both 1968 and 1972, where she was a gold medalist. She was an inventor and implanted the first Charité disc, the first version in a human in one of her patients in 1984. Throughout her career, she's been professor of orthopedics at the Charité Hospital in Berlin. She is a founding member and past president of ISAS, which started life as the Spine Arthroplasty Society. And she's authored more than 200 publications and presentations and posters and has multiple patents. Terry Marnay is the inventor of the ProDisc, both the lumbar and cervical ProDisc. He is a classically trained French orthopedic spine surgeon who's trained in Paris. In 1983, he moved to the south of France, where he began practice at Montpellier Hospital. He started inventing sometime in the 80s, and in 1990, he implanted the first generation lumbar ProDisc in patients in France. In 1994, he became the founder and chief of the Montpellier Spine Center. He has 58 patents in spine surgery, and like Karen, he is a founding member and past president of ISAS and SAS. And we have a nice history. That picture on the lower right is Terry proctoring Bart Sachs and me during the first ProDisc implantation in the US with the heavenly light, the divine light on him. So we like that picture. And last but not least is Rolando Garcia, who's joining us from Miami, Florida. Rolando was born in Cuba as a 2-year-old. He and his family moved to Spain for a couple of years and then to Puerto Rico, where he grew up. He got his bachelor's degree, his MD, and his orthopedic residency were done at Tulane and a spine fellowship in North Carolina. He's been practicing in Miami for 25 years. He went to France and saw his first lumbar disc replacement with Terry David. So I assume that was a Charité, and kind of fell in love with the technology. He was the design surgeon and inventor of the Active L disc along with Jin Yu. He did the first Active L implantation in the US in 2007 and was the PI for the Active L IDE study. So it's just wonderful to have these 3 people. The moderators for tonight are Dr. Scott Blumenthal, Dr. Rick Geyer, myself, and Dr. Chapman, as soon as he can get out of surgery. And we'll try to keep the conversation going and be of interest to everybody just for this unique opportunity. And we'll go through some of these topics. Is like what was the incentive for these people to think about motion preservation, things they might have done differently that went right or wrong, what outcomes they're most proud of, and what they think the future of arthroplasty will be. So I am going to call first on Dr. Karen Büttner-Janz, and she has some slides for us, and then we'll start some conversation and get everybody involved. So thank you for joining us, and hopefully you'll get as much of a kick out of this as we are. So I'm going to stop sharing, and Karen, if you can start sharing, tell us a little bit about the development of the Charité disc and the concepts that you were thinking of.
To see.
Jack, did you stop sharing?
I did stop sharing. Yeah, I see Karen on my screen.
Can you see?
Yeah, it's getting better, Karen. There you go. Perfect.
Yes. Okay. Going back to the beginning. Thank you very much for the invitation to speak here. The goals of disc replacement are, as you can see, maintaining of the height of the intervertebral space and of the intervertebral foramina to get the physiological range of motion, lordosis of the operated motion segment and the entire lumbar spine in the sagittal profile, neutral standing position, and of course, the stability of the motion segment. It started with Paul Harmon in 1952. He operated 13 cases and implanted Vitarium boards as disc prostheses. He was followed by Fernström, and he implanted much more cases between 1962 and 1964. These boards were made of steel. However, the result was subsidence, and for this reason, the disc replacements were not suitable to treat patients. Then it started with a Charité disc. In 1982, we had first ideas how to create a totally new disc, and the first model was developed in 1984 and implanted in patients. The second model in 1985, and then a big step to a real better Charité disc in 1987. The plates were made of chrome cobalt molybdane. The sliding core was always produced of polyethylene. The two inventors, Professor Schellnack and me, Professor Schellnack unfortunately died about 2 months ago. Then the first ever operated patient, 25 years later, as you can see, still motion was available, and the first model worked with only a slight subsidence. Here, an overview about the sizes and angles and of the plates of the polyethylene core, and how to get the motion, how to produce the same as it should happen in the intervertebral space. A normal operated patient of 38 years old, a male patient, and you can see the X-rays 5 years post-operatively in normal standing position and then in extension and flexion. This was really the aim, and it mostly happened, but not always. Here you can see a case with a fused L5S1 level, and typically there was later the adjacent segment degeneration and then disease. In that time, we always had discographies, and there was a memory pain, and this patient was operated again via this anterior approach to implant the Charité disc. Another case I operated was this one. At first, the fusion surgery at L5S1, and at same procedure 2 levels above, the disc implantation, and in prone position, same day, same surgery, the implantation of the dorsal instrumentation. Here, a special case which shows the opportunities of the angled plates. The 10-degree plates were very well suited for the level 5S1. as you can see, as a normal case on the left side, and the right side shows that there was subsidence of the upper plate at level L5S1. Probably too much bone was removed, so that it happened that the subsidence occurred. And to replace partially the bone, the vertebral body, the angled plate was rotated and has done it, so that again the result was satisfied. And later on, the in-motion prosthesis was implanted. It was the same procedure as with the Charité disc. The name changed and a bit the shape of the end plates, and additionally the instrumentation. But this procedure was more difficult because there was always needed a hyperdestruction of the intervertebral space. In my feeling, the former instrumentation was better. Here you can see the timeline of the development of the Charité disc, the beginning in 1982. Then the first and second model. I wrote my PhD thesis about the biomechanical results, and the first 50 patients operated. Then the document of the US patent, the sizes 4 and 5, the coating of the plates. The company always asked me to implant the new types, the new plates, the new sizes, angles at first. And so I remember that especially the coating procedures were very difficult to implant at the beginning because it was no good structure. The implantation was really, really difficult, and it was changed afterwards. Then the name was removed after the big deal. When the Charité disc was sold to Johnson & Johnson in 2004, together with FDA approval. It was sold 1 year earlier in 2003, and 1 year later the FDA approval was possible. And then the in-motion. What is the advantage? What was the special issue of the Charité disc? You can see it was the first commercially used disc prosthesis to introduce via a new treatment method, a new treatment strategy for DDD, and it opened a new market for all disc replacement implants. And some ideas for discussion. First, how to achieve a real physiological range of motion to avoid facet joint degeneration in cases of ball and socket discs, respectively, how to avoid adjacent segment disease and special types of viscoelastic discs. And is shock absorption really needed? There are three literature opinions of Rohr from 1960. He wrote that compression forces are mainly absorbed by the vertebral bodies, as you can see, and that normal discs are very resistant to compression. And I like this explanation because it really explains how it works within the spine, that the blood is going out in cases of much loading, and not that the disc are weak material and compensate the load. Kutz, a German anatomic person, he found out that the intervertebral disc participate in shock absorption only to a very small extent. And in 2012 was published that the nucleus pulposus is designed that only minimal opportunities are needed to correspond moderate daily activities. Thank you very much, and some greetings from Berlin at night.
Karen, thank you. You were definitely the groundbreaker and the visionary. So it's really wonderful to see your perspective. Terry, I have a question for you, because this was during the Cold War, when there was still, the Berlin Wall was still up, and Karen was on the other side of it. She was close to it, but on the other side. So in the US, we had very little information about anything that was going on in East Germany. How was it in Europe? Did you know that Karen was working on a disc, or?
I discovered Charité in November '89 in the French Congress of Cartes. For the first time, we were seeing it, and I have been surprised. Oh, somebody is thinking that we need a disc, like I have done, because I implanted my first disc in February
1990, I think.
90.
Yeah.
So it's 2 months or 3 months after. And as I know, the inventor has two reactions. The first is, oh, I have a competition there. But the inventor have a second reaction is, I feel less lonely. That means this direction is a good one. It's like a race in desert. You have your navigation book, and if the sound is clean, there is nobody before you, you say, I must be wrong on my path. I have to revise my notebook to see where I have made a mistake. And so when you have somebody else that is coming just behind or just in front of you, before you, okay, we are two, so we are not stupid, and probably there is something to do there. So that was my
Aaron.
May I add something? We traveled to France in February in 1989, before the wall went down, to show the Charité this, how it is to implant, but we didn't visit Montpellier, where you are living.
In 1989 I have seen the Charité is a French orthopedic congress.
Especially, we visited Dr. Lemaire. Maybe you remember on him.
He
was very fast to know how it works.
But I had already my disc just ready to start. But I would have been very, very glad to exchange with you.
Well, Karen, I want to ask you a question. So you were a resident when you worked on this. So how did you get the idea to think of the disc replacement? Yes, there were some very early things, but they weren't really disc replacement. They were some type of spacer. How did you get the idea? I mean, here you were as a resident. I look at my fellows today and I say, do you have any good ideas? And here you come up with something revolutionary. So how did it pop up? How did it come about?
It was in the clinic where the idea came up, and there was a wide field of the spine. We knew and were very well educated in replacements of total hips and knees, and all the fusions were done. And the question was, is there also possible emotion retaining device? And so we started to work on it. Was very fast to find who was interested. I was always interested to doing something what is new, what is interesting for me as well. And so we started. Professor Schellnack, he was ready with his PhD thesis. I was ready with my doctoral thesis. And so we worked together. Let's go.
So your professors,
that's a neat story.
Your professors were supportive. They encouraged you to do this because this was really new territory. And I know in the US, there was a lot of skepticism, as you know, and Terry knows, to adoption that still continues to today. But certainly to bring this on as a new idea, it's really impressive that you didn't meet the resistance in your university to do this kind of brand new technology.
I have always the small pieces which I showed on the picture. I have it even with me. The first ideas we had, the metal plate and this one, it's still available.
Wow.
It's history.
And Karen, you must be keeping them hidden in your closet, just like all your Olympic medals. And I have to tell a funny story. I visited Karen in Berlin, and I said, Karen, can I see your medals? She said, I don't know where they are. So she crawls up in her closet and pulls them out. But
I could tell you, last year it was 50 years after the Olympic Games, and from 1972 from Munich. And I was very often invited to give interviews for whatever. And I was asked, what is more important for me, the total disc or the Olympic medals? What would you think was my answer?
I think you would have said the total disc.
Yes. And who did ask me, a very well educated journalist, she was surprised. She said, never in advance I have heard that someone has a higher level for whatever. I was the first one.
And Terry, besides hearing about the Charité, what prompted you? How'd you get the idea in your head to develop the ProDisc?
I remember pretty well. We were in a unit where we were permanently speaking about joints. My boss has invented total hip, and he had my joint was Jacques Vidal, the guy who invented the Vidal frame for open fractures, Hoffman Vidal. Okay, so he was permanently like that. And I was designing joints for kids, for tumors and things like that. So I was in the design of joints. I was in charge of that. And I see a Venezuelan professor in university or assistant, Spanish, and in Spanish, and she came and she had no more disc. It was the first time I have seen someone with no disc, all the discs destroyed, kyphos, but no scoliosis, nothing like that. So what could we do? We had nothing. We had not femoral rings. We have nothing. And the only fusion we could do was posterior plates. Okay, that would not work. Or anterior Zilke, but it was it was creating more kyphosis. So I had no solution for her, except to put a brace and say, okay, you are part now of the suffering humanity. And I was completely devastated not to be able to do something. So I said, and I told to the boss, you see here, we should invent a disc. And my boss, who was specialist of invention, he said, okay, good luck. And I was, that I've worked on from 81 to 84, 86, 88 on the spinal balance. I was thinking that for the spinal balance, the best was the patient can choose by himself and not to fuse in a position. Especially at that time, we had nothing. Imagine that in 1988, when I have finished the design of the prototype of the disc, we had no pedicular screws for fusion. We were only for plates. We were still with hooks. We were still operating Harrington with Harrington rows and screws fixed on the rows. We were not, imagine that Cottrell Duboussé is 84, but just for scoliosis. We don't use it for something else. So, and I was developing my system of fusion at that moment, but always thinking that we need to restore motion. There is no reason that you have motion in knees, not motion in hips. It's not because there is more disc, but we see, okay, on one level I could accept, but several levels it was unacceptable for me to fuse people for that. It's very important. I benefit of my experience of knees and hips, and especially in kids and the customized one. That's why the design is like that. That's why the poly is constrained. That is the experience of the knees. That's why it's a dome of poly and not a cup of poly. There is a lot of reason by experience of the materials, tribology of the materials that I have used for the joint design I was making, customized design. That's why I was able to make my millimetric and plans by myself, because you had to take your measures and deliver the plans to the customized manufacturing when you were performing the implants for kids or things like that.
Scott, you have something to ask us?
Thank you for recognizing me. I raised my hand to try to talk over anybody, but I do have a question for both Karen and Terry, because we're talking about the 80s here, and I trained in the 80s as well. And in the US, anterior spine surgery was not the real predominant approach that we were taught. I happen to train with a surgeon that did a lot of anterior fusions and had access through a very safe retroperitoneal approach. But anterior spine surgery back then was, a lot of people thought it was too morbid to do, and that you'd have to make big incisions and things like that. Was the climate different in Europe such that you obviously had the designs in your head for motion preservation, which we all love right now, but the concept of just being able to do quick to recover anterior lumbar spine surgery with low complications, was that kind of a new concept in Europe, or was that fairly well accepted?
Karen, can you answer that, Karen?
In the Charité hospital, it was very well accepted because they have done a lot of anterior surgeries for fusion, all levels of the spine. And so it was not difficult to implant the disc and not difficult to learn the approach, even if someone started. And my own experience, I have always done, I was always more interested to do the anterior approach than the posterior approach. It was easier for me, the anterior approach, really.
Yeah, in France, we had the chance, we had René Louis in Marseille, and René Louis is one of the father of the anterior approach. But if I have found some conference in the French Orthopedic Society on anterior lumbar fusion after recurrent disc herniation from 1949. So it's probably because all of this generation were general surgeons before to be spine surgeons. So the anterior approach, René Louis anterior approach was every day. So, and we had also a lot of deformities with poliomyelitis, and it was or spina bifida, and the only arthrosis you could do was an anterior approach. So we were used to that. But you had the French School of Paris, Wakami was against the anterior approach, only posterior plate and screws. So, there were two schools, the school of posterior approach and the school anterior and posterior approach. And when you had them both, but sometimes, now, you perform an L5-S1 skinny woman, you can perform that in 25 minutes. At that moment, it was 4 hours, and it was a polar expedition. You take the sandwiches, you take the you take the thermos with the coffee, and because it was long, because we were controlling all the vessels, it was and the day we started to be, but we were performing that two times a week. The day the disc arrives, now we have seen some colleagues are performing 6 to 8 anterior approach a day. So that has nothing to deal. You imagine that my boss has probably performed, I would say, I know for spondy is 143 cases in his life, which is a lot of anterior approach. But I have now performed between fusion and disc 8,000-10,000. So nothing to deal. I understand it was complex before, and today it's an everyday procedure. But remember, you have been trained in the same years. In the 70s, to put screws in the pedicure was considered as a crime. Very dangerous. You will put the screw in the cord, and that cannot, and it's forbidden to operate fractures because you cannot use anything else than the pedicure screws of Rakami, and in a lot of units it was forbidden like a crime. So, and today every assistant after 2 days can put a screw with assistance of robot or no assistance. So it's just a question of it was too early.
Rolando, sorry, Terry. Rolando, I just want to kind of center us back towards the invention stage. So you had the benefit of seeing the Charité and the Protist as we did, and then you came up with the idea for finding a different ground, a middle ground, using the best and least best of things that you had seen. So what were the thought processes in designing the Activ-L after you had already some experience with both Charité and Protist?
Thank you, Jack. First of all, I just want to say that I feel humbled to be in the same stage as Professor Büttner-Janz and Thierry. I think that they are really giants in which I truly stand on their shoulders, and I'm just really honored to be here. The Activ-L was sort of the child of the Charité and the Protist, and I think that it came. I think that one of the things that I thought, and I think that people can comment, I think the Charité prosthesis is in a well-selected patient, just really a wonderful implant. It is not the easiest implant to put in, and we learned a lot through the beginning. I remember being proud of taking fluoro shots of me eating up the posterior rim, the concavity of the bone to make that end plate straight, and then we would have obviously the problems with subsidence. So, I started thinking, maybe those posterior spikes, maybe I wouldn't do that. Maybe I would try to do some sort of anatomic plate. Had the experience with the Protist, which is also a wonderful implant, a little bit easier, I think, technically to put in, but never really, and this is just my personal, never really was in love with putting the polyethylene as the last step after the implantation of the plates. Also thought that there should be some more options in terms of initial end plate fixation, and obviously we can debate that. So if you look at the Activ-L, is sort of like a Chinese menu of picking the best things of two different menus and then just trying to come together to something in the middle. I remember that in some of our first meetings, Jim Yu and I met with at the time it was Oliver Burkhardt, and we met, and one of the first discussions we had, everything was going great. And I said, well, I just want to say I'm not going to put any keeled implants. So if you make a keeled implant, I'm out of the project. And then Jim Yu said, well, I just want to say that I'm not going to put any spiked implants. So if you make it spiked, then I'm out of the project. So we're like, okay, we're at an impasse here. So he goes, well, why don't we do both? I go, well, yeah, sounds fair. And we also basically talked about that in terms of the mobile core, which I think I would love to hear both Karen as well as Thierry talk about it. But I think that that's a very important topic, and I think a topic that I think we can talk for the next 2 or 3 years about it. But obviously, one has a mobile core that has quite a little translation, and that makes sense in certain theoretical aspects, and then the other one doesn't. And we said, well, what if we have something that is sort of in the middle, that has a controlled amount of motion? And so those were the sort of the main issues that we had, the sort of the wish list that we have at the beginning of it.
And Rolando, were you involved in the design of the FDA study to control it against both ProDisc and Charité? I mean, how did those discussions go? Because it was fascinating, it was interesting, although
Yes.
at the end, Charité was off the market by soon after the study came to completion. So tell me a little bit about the design of the study.
Yeah, so the first thing that was fascinating is that for those of us, Rick included, and Scott, of course, even more involved, when we did the Charité study, we paired it against the BAK because it was the anterior, it was FDA approved for the anterior approach. So we really wanted to do a disc to disc study because I think that most of us that are in this panel have gone through the extreme difficulty that back in the days to tell someone, well, I'm going to either do a disc replacement or a fusion. You will find out afterwards. And that was a very, very difficult conversation to have with patients, because if you explain it one way, they would go, well, there's no way I'm going to do this. I'll tell you what, I'm going to fly to France or I'll fly to Germany and I'll have it done. So that was a very difficult discussion. So we said, okay, well, we have to compare FDA approved discs to the Activell. But we did not want to submit surgeons to a new learning curve of an implant that they were not familiar with. So we said, I think that the fairest way is that the doctor chooses the control disc, and then obviously the study. So in the study, if you are randomized 2-to-1 to the Activell, but if the control group was selected, it was up to the surgeon to select whether to use the ProDisc or the Charité.
The reason that they dropped the Charité as the control was not because it was taken off the market, is because it was half ProDisc investigators, and they weren't as good at putting in the Charité as the it's a harder disc to do, so they couldn't do it. So we kind of had to do the easier disc for the ProDisc investigators in the study.
And you just made that up, Scott, or did you dream that?
Yeah, I think Scott just made it up, but it is true. And Karen, I think, can attest to it. Scott and I have some very long-term follow-ups of our Charité. In fact, I have a gal with 21 years and she's doing great. And the disc looks fine. But as Scott said, it was a very, very finicky disc in terms of guessing the right, not guessing, but picking the right angles. And we didn't have all the measurements we have today, but he and I did well with them, and we have a lot of really nice looking disc. And obviously ProDisc has wonderful long-term follow-up. But the thing I'm curious about, and I'd like to ask all three of you, maybe starting with Karen, what would you change about the design of the Charité if it was still on the market now, Karen, and Terry about the ProDisc, and then Rolando about your disc?
The axial rotation is unlimited in the Charité disc. I believe it is a disadvantage, as it is the case in all ball and socket discs. I believe the aim should be to really have the physiological range of motion. Of course, not every patient has the same range of motion in all the discs, but the unlimited range of motion is not the final version, I believe. There should be some change. And regarding the material, the newer discs, I believe they are made of PEEK and ceramics. And if this is the best sliding combination, I don't know. Let's see how it will work. The Charité disc, the polyethylene core, of course, there is some altering of polyethylene, but the long-term results, including of the ProDisc, also there is a polyethylene, they do not show big disadvantages. So I believe that the polyethylene is still suited for total discs.
And Terry, how would you change the ProDisc? Thank you, Karen.
I will say what I will not change first. I would keep, just to be in contradiction with Rolando, I would keep a fixed core, because I think but it was my idea, the fixed core as a better resistance, because it's constrained, it is based better resistance to the load, because there is no plastic deformation. It's not doing like that. I will keep the ball and socket, because one of the problem of the disc is that we cannot, it's a problem, and I have not resolved it. We cannot restore all the degree of mobility, because we have no more posterior ligament and no more anterior ligament in almost all the cases. So those are providing some stability, and the ball and socket is taking care of this stability, like a posterior stabilized knee takes care of the lack of posterior ligament. So it's important to understand that without ligament, perhaps we cannot let the same capacity of translation in all directions. So that is what I would keep. After that, probably my obsession of the knee and the bad results of the knee without keel has pushed me for the first version to put 2 keels, and after that to put 1 keel. Perhaps the keel is, in some circumstances, too much, and we could probably have 1 line of spikes, but in the middle, to be sure that we are to be guided by that. That's important, because you remember, when you have no keel, you have some difficulties in some cases to maintain the centering during the introduction. So the keel is there to guide you. But an option without keel and with a dome, like we have made for the Vivo in cervical, yes, but not in all the cases. And right. now we have the capacity to analyze the concavity. We have better X-rays than in the 80s. So we have a good CT scan. Imagine that it was impossible to get a scan for a spine in the 80s if this was not a suspicion of tumor. A CT scan or MRI for a patient with just a low back pain, you have to wait 1 year. And it was because it was reserved for the big lethal disease like the cancer. So today we could probably have a dome is more adapted. So when there is no more, it's flat, we can put a keel. When you have a concavity, we can put a dome. It's exactly what we do in cervical when we use SK or Poly-C in one hand and Vivo in other hand. It depends on the shape of the space. I think that we could make it better.
Okay, well, I'd love that. You tell Sentinel we want the dome. Now, Rolando, how would you change the active valve? So you have dome on the top and bottom.
Yeah, so first of all, Thierry, as always, has these brilliant ideas. First of all, the one thing that I would do if I could, and I don't think I can, but I would make a disc totally radiolucent, because sometimes we get hung up on things that are not really important, the clinical outcomes, the motion. But if you could have a disc that functions great and it was totally radiolucent, you would say, look, it looks perfect every single time. I do think that if you could, from a biomechanical standpoint, make the end plates thinner so that the polyethylene, even when it was smaller, would still have motion. I think that we can all agree that when you put a smaller polyethylene core, sometimes you have burnishing of the end plates posteriorly, typically, and I think that number one is that reduces the range of motion, and that raises the potential for metal debris. So if you could have this like super metal that was super thin, and you could have a small polyethylene and it would still be able to withstand all of the forces. I think that would be great. And just to, and the other part is just what Thierry alluded to, is I would have, I mean, almost to the point of the ability to almost, 3D print the end plate, so that you get a CT scan, you map the plates, and then the implant goes in, and you know that you're matching, you're putting you're not putting a round peg in a square hole and vice versa. So I think that those are all things that I do agree with Karen. I think is brilliant that I don't think that the shock absorption of a artificial disc is that important. I don't think we've seen that to be important anywhere. And but I do think that matching the anatomy and the surface of the end plate to the patient, that I think is great. And it goes back to, I think that one of the really pioneering things about the Charité is it had a bunch of different end plate sizes. It had a bunch of selected, I think that one of the things that was done very, very smartly by ProDisc was the 0 end plates. I think if you're going to be doing an upper to middle lumbar level, you have to have 0 end plates. Otherwise, your implant looks like it's in flexion. So those are all things that I think that we need to get better.
I have a story about that. In the first version, the 2 kilo one, with a 1 block insertion that you like, at the moment to manufacture the first series, the small company, without asking me, decided to make some economies. I understand they didn't know what they will do with that if it doesn't work. So they have just put the angle in the superior plate. And they have not manufactured the angle in the inferior plate. They were designed since 1988, yes. And the problem is, as I stopped my first series to put my patient in an incubator and to see what happens 7 years after, when we arrived in face of FDA with this pilot study, they say, oh, no inferior angles because you have not tested them. So for a decision of economy in 89, the Lord of the Shift inferior plate for the ProDisc arrived in 22 in United States. I've been approved in 22, something like that. So 32 years after. Wow. So, and just because they have to make some economy and could not manufacture at the beginning enough products of both with the angle. So I arrive there and they say, oh, we manufacture but only the superior plate angles. If you don't care. Well, I say, we need them both. No. And so sometimes, I was waiting for that. I got them in 2004, but with the regulatory, it took 18 years more to get it in the United States.
Yeah, it's too bad the regulatory process really slows down a lot of the advancements.
That's because nobody is involved to make it changed. The regulatory process, how many measures there is on the ProDisc lumbar? 215 publications on the big journals peer review. How many on ProDisc lumbar? How many in range of motion? We have one who has made the criteria of measuring. 1 or 2 are speaking a little bit, but nobody has really measured that. Why? Because it was forbidden to measure the motion because the fusion could not be measured. So it was not a criteria. So nobody has done it. by measures of 270 ProDisc 2 levels, I have said I published last year in NAS. It's the first time there is so many measurement of motion. Nobody has, oh, it moves, but there is no real study. It's very funny, and it's not our fault. It's our fault a little bit, but it's because the control group was fusion. So you cannot take advantage of the incapacity of the control group. That is something which is crazy in the mind of the guys of FDA. I'm sorry, but that's not possible. You imagine, you perform a total hip replacement compared to a hip fusion, and you have not the right to use the advantage of the motion of the hip. Why do we operate a hip? To make it move. So it's sure that an amputation, when you have fractures, has never infection of the bone. So it's exactly that. That is the most stupid thing.
Can I throw another question out to the panel? In the chat room or in the chats, there's some discussion going on about poly heights and disc heights. And I can say, based on at least the TBI experience, there's definitely a finite percentage of postoperative radiculitis that we think perhaps is from distraction of a collapsed degenerative disc, obviously one of the indications for the surgery. Do we need to maybe think about, and this is the question in the chat room, some lesser disc heights, and will the biomechanics support that more importantly? And maybe I'll throw it to Rolando first because he gets to talk the least.
So I think that that's definitely something that we are learning very quickly from the cervical experience and how it seems like the newer and newer products are coming out with smaller and smaller implants, and how we did publish this before I presented it, but it was interesting that at least with the Active-L during the FDA trial, 85% of all the implants were the smallest implants, which was the 8.5. So I was talking about if we could really make that metal plate thinner, because obviously the 10 millimeter polyethylene implant moves better than the 8.5. It has more room to move. So I think that if we had the technology and if we could, I think that there would be a role for some of that. Yes.
And in the chat room, and I had frankly forgotten about this, when Charité originally came up, there was actually a 7.5 height. And Karen, you may want to comment on the lesser disc heights to avoid over distraction of the disc space.
Yes, I fully agree. It makes really sense to have in the height small total disc, especially for the cervical spine. As it is probably known, I have many patents and in the meantime, very good prototypes for new discs with motion according to the normal spine, with limited motion and not with hyper motion, as it is the case mostly up to date. And in our aim was to have the most possible height of the polyethylene core, because the metal is stronger for the future, in the future, over the years. And if there are changes, then it will probably happen with the polyethylene. And for this reason, it should have the height of at least 1 millimeter and never less than 1 millimeter. And so I believe it's important for the future to have also bigger end plates, that they cover the end plates of the vertebral bodies. Maybe it helps to avoid heterotopic ossification or to reduce it. It is also important to speak about the size, the surface, which is to cover on the vertebral bodies.
Thank you, Karen. Hey, Terry, I just wanted to comment on the frustration that you vented with the regulatory agencies that we've put up with, certainly in the US for the last 23 years. But just on the flip side, even though it's been difficult and very expensive to do these FDA studies and frustrating to take so many years to get FDA approval for, so for example, the 2-level protest, that study was completed so many years ago. But on the good side is it made us be scientists. You know, they made us capture a patient population and follow that population so that we have really good data on the performance of patients who meet the selection criteria. So I can sit with a patient in my office and say, you would have been in the middle of the bell curve. You would have been the perfect patient to enroll in the study. And therefore, I can tell you with confidence that in 5 years and 10 years and 15 years, you will do well. It's not a guess anymore.
I agree.
So that is a wonderful gift that we got at the expense of frustration.
Don't worry, we have now the new regulatory here, which is not, it's worse than yours. I would say I learned 2 things through all of that. The first is, as soon as you think about and until you have finished, you record all. And you should also even record the patients you say no, because it will be the best for you after that to determine your indications. And we don't know that. We don't register, we don't record the patients that we refuse to put a disc. We don't pay attention to them. And I think that at the moment we have a patient and a study, we should record the same way, all the patients with the same pathology. But this one because he has a hepatitis, this one because whatever. Because at that moment, we could have first a control group, our own control group, doing something else, nothing or fusion, but also that oblige us, because I learned from the United States that my first study of by chance I stopped at 64. It was easy to reconstruct all the study, but and the pieces missing by chance when I restarted in 99 with I will say the Damocles sword on my head of the FDA. I have recorded all. That's why I can publish 21 years and 1,000 patients, because I have all. All is there. As a second point, what I've learned, to come back also to the pain we had. You remember, I remember a discussion in Phoenix with the gentleman who is called Rick Geyer about the patients with pseudo-sciatica, nervous pain after the surgery. You remember? And it was in Gary Lowry meeting. And I remember I answered to Gary, you know, in my first, I had 30% of patients who had pain in their legs and buttock and hamstrings. After that, looks like sciatica, I'm not sure. So we are discussing about, is it on the side we have on the left side when we go from the left, because we have a pulse that has collapsed. So we put pulse recording in all our patient grade toes. It was not that, because it has disappeared. And you don't speak about it now, and I'm not speaking about it, and we don't see it anymore. What is the difference? The difference has been the gentleman in front of me, who is called Jai Ziegler, taught me that without knowing the consequences. The release, and the release. At the beginning, we were not cleaning our spaces as we clean it now. And this remaining disc, which is toxic, which is acidic, which is an aggression. And if we let a little bit of it, when we put the disc, we push it. We don't. we have to make the garbage empty. We have to clean all of that. And as long we are cleaning well now from posterolateral corner to the other one, we have no more. That kind of pseudo-neurologic pain during several months. And I think it's thanks to Jack who has explained it, we have to clean and clean and clean the space. It's very, very important.
Karen, did you have a comment?
There are questions from the audience. Would be good to give the answers.
Well, there was one question, Karen. I think it was based on what you said about maximizing end plate coverage. And
Yes.
they said has yet to respond to the need for a 7.5 millimeter inlay. What does the panel think about the eventual introduction of 3D patient-specific end plates, which I think is the future, but who knows when?
It was answered.
Yeah, we
Yes.
talked about it.
Listen,
Who
out of
will
respect,
But-
out of respect for our European guests who are staying up very, very late, we've reached the end of our hour. But I just wanted to thank Karen, thank Terry, thank Rolando, and everyone who participated in just a wonderful experience. This was really great. I'm sure Jens Chapman will watch this and regret that he couldn't be here also to participate. He was looking forward to it. So everyone call in for get your CMEs. Karen and Terry, thank you very much.
Thank you for hosting us.
Absolutely.
Yeah,
and-
thank you. This was great.
Thank you for having me.
And
Absolutely.
thank you both for staying up till 3 a.m. your time. And Rolando, thank you
Thank
for
you.
staying up till 9
Good
o'clock.
night.
Thank you for having me.
You're terrific.
It's great to see
Okay.
you.
Thank you,
That will be
everyone.
3 hours
Me
to
too.
sleep.
Thank you very much.
Bye-bye.
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 Great.
Bye.